very short read that, and you have that 112 content that you can go back to if you don't understand the malignant transformation and the cancer development, initiation, and promotion, progression, and metastasis, and the higher the grade, the worse the prognosis is, and the harder it may be to treat because it's so far away from the normal cell, the cell that it came from. And then the staging, when we do that TMM, I think most everybody got that question. Many of y'all missed that. Kids, but I think most of the class got that right about the tumor and the nodes and the metastasis. And that mitotic index is a percentage of the actually dividing cells, and the more cells, the faster the cells are dividing, or the more cells are in the division process, and the more aggressive it is. But then, and that may be, though, sometimes the high mitotic index cancers can respond quicker to radiation and chemotherapy because they are dividing quickly. So there's a little trade-off sometimes. And they can respond quickly, but sometimes they can come back quickly too. So we'll talk about that later. This may not be exactly what you had in your article. This one was from the former one, but I'm going to go ahead and leave that in there. They actually were promoting erythropoietin for the cancer-related anemia and HIV-related anemia as a quality of life issue. And now they're saying, and I think in your article it said you're not to give it just for the quality of life because what were some of the risks that you could have with erythropoietin?
You may cut some in there.
Early death. Increased risk for DVT. People with cancer can have increased coagulability. That's what it really is. Some cancers with that perineoplastic kind of stuff will increase clotting, just the cancer itself. And then you give them, have you ever heard of the gestral acetate or megase to give to people for appetite? Did y'all talk about that with HIV? It is approved. It's a liquid now, but or you can get it in pill form too. But it actually was a breast cancer treatment, but it was caused tremendously increased risk of DVT. So if you're giving them something that for appetite, and then you've got cancer that causes them to be hypercoagulable, then you give them these erythropoietin-stimulating agents. Then you've got this multifactorial triangle there, or maybe even more factors that they're going to make them more likely to have a DVT. So, just review that for sure. There's definitely risk for it. Avoid the drug companies making some huge money off of that. And I think that I'm not sure how it's working because it's Procrit is the one that was. It's actually exactly the same thing. Procrit and Evogen are exactly the same thing, and they were manufactured to begin with and approved to begin with from the same company, Amgen company. But then they were sold to different companies to market them. Because the Procrit was marketed by there was another company, Johnson & Johnson, but they're just huge conglomerate. But anyway, and then Evogen was promoted by Amgen that started making it. But anyway, they really, I think they do probably still use it more in dialysis patients because we all know that the erythropoietin's produced where? Yeah, and so if you've got kidney failure, then erythropoietin's going to fail a lot too, isn't it? So, and I bet a lot of y'all have seen that because we see a lot of patients coming in, maybe not because of their renal failure, but they're coming in with some other problem. They've got renal failure and they're using it and all that. But in dialysis, they probably do still use it a lot, even though there's risk because they really do have poor perfusion and have but we don't want to cause people to die sooner from the cancer. But with dialysis, it's a different situation. Yeah, Joey. Oh, okay. I thought you were raising your hand. You just moved. All right. So. Chelsea was asking me a question about this, and she must not have seen the memo thing. But y'all, I need to tell you in the book. Did y'all see that in the book it says bradycardia? And I didn't notice that. But there is a place in. It's not actually in the oncologic emergency section. It's actually in, and you have to look it up. I looked it up, and I don't remember if I put it specifically in the reading about the. Did I say specific pages for the cardiac tamponade? Because it is in a different section.
Yeah.
But it does say bradycardia, and I told Chelsea yesterday I found it in Diseases and Disorders. I looked it up in other places just to see if there's some period of bradycardia at some point. But there's different phases of cardiac tamponade, and we really don't need to go into that with this particular situation. We just want you to have a basic understanding that this can happen, that fluid can accumulate in a pericardial sac, and it can constrict the pericardium, and sometimes cancer can cause pericarditis, and that's actually where it's discussed in the book, is with pericarditis. And Chelsea, I got your question thing. I'm so glad you said something about that, because I just did, just reading through that stuff, I didn't notice the bradycardia thing. So did that help that I sent you the thing from Diseases and Disorders? Did you? Because I sent you an email with it, did it? Oh, okay. But anyway, it does. What we're gonna go with, and I'm gonna ask Ms. Rumble and Ms. Lowe when I get to see them. They're both in clinical today. I'd rather talk to them in person anyway. But we can see if there is some point where you might see bradycardia. But what we're really seeing is heart failure and decreased cardiac output. And when you have decreased cardiac output, then what would you expect your heart rate to do? To compensate. I mean, it may slow down at some point with that constriction, but when the cardiac output is starting to decrease, then the body's going to try to compensate by the tachycardia. So we're going to go with the tachycardia.
Okay.
But I was telling some of the people when I first came in that so sometimes these books just have mistakes in there, and they're not misspellings or anything. It's just the wrong thing. They just don't. The people that proofread don't know what words are supposed to go there, and so they're okay. Yeah, that's spelled right. That's fine. But these are the things that we want you to see, and you don't have to know this on a deep level. We've got lots of people in this class that love to understand everything on the very deepest level, and I don't understand it on the very deepest level. So you're going to have to go to another expert if you want it more than what I have on some of this. But it is you're going to see this again in cardiac, but it is something that can happen with tumors. So you can have fatigue, and you do end up with the tachycardia, the hypotension, and that pulsus paradoxus, that you're going to have a 10 millimeter of mercury difference with inspiration than expiration, so that it decreases the systolic blood pressure on inspiration about 10 points more than it would have been normally. So, and the pulse pressure, you know what that is?
The difference.
Systolic and diastolic, exactly. I got that. So, and so the heart's definitely compromised, and so that's really what you need to know with this. We don't have to go any deeper than that. But I like to, y'all said. Some of y'all were saying that Mr. Henley talked about that in anatomy and physiology, and that some of y'all have heard this before. How many had Mr. Henley and heard this stuff? So y'all, this makes sense to y'all probably. Am I saying anything wrong with all this stuff? Do y'all remember anything else? But I'm not a cardiac nurse. I just know that, and I have had a patient, or I remember one in particular that ended up having to be treated for it, and it just came all of a sudden. She had breast cancer. That was metastatic, and but if you don't remember what tamponade means, this is gross, I guess, to say it, but a tampon really means plug, and that's a French word, is to plug. Tamponade is to plug, and so that's, if you're talking about tampons, that's what some girls will call their female hygiene products. Their tampons, they'll call them plugs. I've heard some of my friends will call them plugs. And anyway, if you think about that, tampon means plug. It really it is plugging up the pericardial fluid, and it's trapping it and making it constrict the heart and decreasing the function. So if it is, sometimes when it's an oncologic emergency, it comes on really quickly, and it can actually cause vascular collapse and all that. So that's really when it's an emergency. But sometimes with the pericarditis, it can be chronic, and the pericardium can expand and it says it can hold as much as 1 to 2 liters of fluid. I think that was in that article that I sent you from Diseases and Disorders. But if anybody wants to read more about it, it is in Diseases and Disorders and gives you some more details. But anyway, that's amazing that you can hold 1 to 2 liters in there without symptoms for a while, and that's because it's not constricting it until it gets to that point. But sometimes if it's so inflamed, the pericardium is really inflamed, it gets hardened and stiff, and that's when it's really, really dangerous because there's not any here for the heart to expand. You know, as long as it's flexible, then the heart can still expand with the fluid in there. But if it's not, or up to a point anyway. But if it's hardened and it's not flexible at all, not elastic anymore, then that's when it really, really traps, and you need to get rid of that fluid. So anyway, it's in IGGY pages 765 and 766, and it's under chronic constrictive pericarditis. And it's not always that type though with cancer, but it can be. And you can get the diagnosis by echocardiogram or X-ray. What does echocardiogram measure? Some of y'all have had patients with that. I know in my clinical group anyway. What does it tell you? When it tells you sizes of all the chambers of the heart and everything, and it tells you how much blood's being pumped out with each heartbeat. In particular, what's the ventricular volume? What do you? The ejection fraction, right. So where we can measure the ejection fraction, and when that goes low, you know, then we might be able to tell from that. But anyway, here is a. I hope that will show. This was just a like here, you know, on a white background, but there's the heart. Here's the pericardium is the membrane that lines the heart, like we have pleural membranes that line the lungs, and that's between the actual heart muscle and the chest cavities where the pericardium lines, and so the fluid can accumulate. But as long as it's flexible, that once it takes up a lot of the chest cavity, of course, it's not going to be a good thing. But you can kind of see that if this is not going to move, then that heart's going to it's going to fail. It's not going to be able to pump much blood with each heartbeat. Oops. Let's see. So what you do is to reduce the fluid around the heart, and you can actually go in with a needle and just pull it out with a syringe. I've heard of doctors doing that before, fluoroscopy or whatever. So when you have to do that, you don't want to punch your heart. It's gross to think about. But anyway, they can actually do a pericardial window, or they can even do a shunt. They call it a indwelling pericardial catheter. It's like you have a shunt from your ventricles in the brain, you know, when people have hydrocephalus or something like that, you really just shunt the fluid, sort of like that. And so you can test the fluid for cytology if you don't know where it's coming from, if you don't know if it's a cancer situation or if it is just inflammation. You can have fluid accumulation with inflammation for other reasons. It could be infectious. So they may do culture to see if there's organisms that are actually causing the problem. Anyway, you look for cancer cells on cytology and culture. You look for organisms. So is that clear enough to just realize that can happen? That's really the basic that you need to know at this point, because you are going to see it again. Okay, superior vena cava syndrome. You're not going to see this again. And that's obstruction by tumor, or sometimes it can be by clots in the superior vena cava. You don't see it except in SVC, that's what I'm talking about there. So you're going to see facial edema and extension in the chest veins and seizures, possibly because of the increased blood pressure that can result in headache, of course, from blood pressure as well. So lung cancer and lymphoma are the most common causes of it. Sometimes you'll see it with breast cancer. But you can start with some facial edema, sort of looking like a Cushing syndrome or the moon face, tightness in the collar, edema of the arms and hands, shortness of breath, and epistaxis is nosebleeds, and the upper body looks real red. And then there's a lot of visible surface distension in the neck and chest veins, because they're trying to the body's trying to develop collateral circulation around where the blockage is, and so you can see a lot of blue here as they make these pictures that picture actually really worked. And then with late changes, if you don't take care of it, then there's going to be hemorrhage and cyanosis because you're not able to perfuse if you're not able to get the blood to return back to the right side of the heart to get oxygenated again. And that's where the superior cava is doing, trying to get everything from the upper body, the arms and the head and neck and then upper chest and everything. It's taking it back to get oxygenated, and that's not happening. So, and then mental status changes and hypotension and then decreased cardiac output and death if you don't do anything with depression. Show you this. This is a cool thing that Dr. Black showed me when he's assessing somebody that that he's seeing that their face is full and their necks, the neck veins are distended, or the whole neck may be distended by the time you see them sometimes, and that's not a good prognostic factor if you present with that. That's a very poor prognosis if you've had the blockage of the vena cava to begin with. But y'all notice that, especially like when you're starting an IV on somebody that has difficult veins, you're gonna make their arms kind of dependent, or let gravity work a little bit, right? Or maybe heat them up to dilate the veins. Well, I was showing this to my children. We were waiting in line at Williamsburg one time, and it was like 105 degrees or something. We were trying to distract ourselves because we were burning up and everything, and I was showing them how huge my veins were with my arms down and with being warm like that. But when I raised my arm up, you can just see, and y'all could try that now. Just hold your arms down for a minute, and then raise it up and see if you have visible hand veins. I really do. So, but that's a way to tell if you're having emptying, or if you've got clear superior vena cava. If the venous if the veins decrease in size, but if it's blocked, they're going to just stay dilated. So that's really a kind of cool way to see. Especially and do that sometime when it's really hot, and it's going to be hot before long, and your veins are really dilated, and try raising it up and seeing it. It's really a neat thing that the gravity tells you. And this isn't really a nice thing to say, I guess, but Dr. Black had a humorous relationship with one of our lung cancer patients that had superior vena cava syndrome, and she was so weak she had to be wheeled around in a wheelchair, but she had gotten so huge up top, and it really made her breasts swell too. And she was trying to do it, but all the purple references in her chest, but anyway, she wheeled her in, and she's like, hey, if I could have only had breasts this big when I was younger, I could have made a lot of money and dancing or something like that. Or really been popular and all that stuff. And said, gosh, if I had a baby, I could really do some breastfeeding, couldn't I? Dr. Black goes, you know what, Janice? I think you could fit the whole kindergarten. Okay. So here's a picture of it. That's in your book too. This is and this one says it's from 2006, whatever, but it's in your book now too. So it's actually figure 24-6 in your book. This was an older version of the book, and I didn't switch the picture. It's the same thing. But what you want to do is treat the cause of it. If it's a lung cancer or breast cancer or whatever, you want to treat with high-dose radiation therapy, zero in right there, and get those cells to die quickly, or you may have a stent in the vena cava to help get help move the blood into the right side of the heart. So you want to treat the underlying disease that is causing this, if at all possible. And that's some people just present, like I said, with that, and they may respond really well to radiation and chemo, but it is a bad prognosis if that's the way you show up. And here's this one doesn't show up that great in here, but in your book you can see it really well. I don't think I wrote it down. It's figure 24-7 in your book. This one says something else, but 24-7. And you can see their face is swollen, her neck and her supraclavicular area, especially right here. And it really does show it better in your book, I guess. And if it's maybe on your computer screen, you can see that that's not a normal shape for a person's supraclavicular area. And the existing smaller veins try to work harder to return venous flow from the other body to the right side of the heart to get oxygen. And then when it's backed up, the body tissue perfusion is and the big thing, I guess, is the brain and the heart, which you're going to worry about up there. Okay, we're going to jump around here. And again, you don't have to know it on any deeper level than what I just told you. It's in your book. I think what I told you is more than what's in your book anyway. But sepsis and septic shock is a common cause of death in patients with cancer. And why is that? Why are they susceptible to sepsis?
The immune system.
Immunosuppression, of course, yes. And so we were talking, Todd and I were talking about incorrect questions and all the time in health for the seniors doing reviews on immunity and cancer on Monday. And I was trying to ask them how to approach this because I don't know where else is doing and all that. And she said, let's talk about, how people are immunosuppressed, blah, blah, blah. And that a lot of times, and I think I said this in some of your other tests, is that well, even back in 111, we talked about infection, didn't we? And I said that most of the time, if the answer choice is something to do with infection, then that's probably going to be the right answer. And she said, yeah, you're probably right. If it has to do with somebody with cancer, then you're going to. That's not always. I don't want to lead you along with that, but you do want to make sure that because that is one of the biggest causes of death. It has decreased deaths with the nucogen though. The colony stimulating factor that stimulates neutrophils, and so that just remember that can help prevent people on chemotherapy from becoming as immunosuppressed. It doesn't mean that they're not at all, but it does decrease the incidence of sepsis and febrile neutropenia is what they call it. That's very, very dangerous. And people go to the hospital with that and die sometimes after therapies, especially chemo, but sometimes with radiation too. So, and then the pulse pressure can increase with the septic shock. That's a shock thing, is pulse pressure increasing. And then the bottom drops out with the vascular collapse. And vasodilation happens to begin with, and they feel weak and warm and flush and maybe have fever and chills. And then the cold phase is that there's not the perfusion to the extremities at all. The perfusion, the body knows to prefer the organs, the major organs, to be perfused if you don't have enough to go around. So you're going to be cold and moist, and then there's not going to be urine output, and then the mental status is going to suffer because it's more difficult to get the brain oxygenated because it's sort of peripheral, isn't it? And then death can come from respiratory failure and cardiac failure and renal failure. And I think your book, or this version, actually put sepsis and DIC right there together, and they are in situations. And DIC is very hard to understand, but again, it just takes what your book says and what I'm doing is I combine some sources. So that's another reason I don't want to get rid of my PowerPoints. This Lawrence was talking about that this week again. You gotta stop it now. You gotta stop it. But I feel like I've gotten a lot of sources, different sources together that can give you a more comprehensive view about what's going on. Because your book's good, but it's there's some other ways of expressing it that sometimes I think might help some people. So y'all have to tell me if I'm just telling you too much. But I think sometimes we can say it in several different ways, and some people can do it one way and some another. But we'll see. Is this helpful so far? This is some other sources that from what you read, but not that you don't need to read. You definitely need to read, but this is some things that I've learned along the way, and then the other sources that I've read too. So, but anyway, this is definitely a life-threatening situation. And there's a high mortality rate with DIC, disseminated intravascular coagulation. Even if you do everything right according to what the standards of care are. It's still high in mortality rate. And so hypoxia and shock and cancer, especially sepsis related problems with cancer patients. And sometimes cancer itself can cause some clotting factor problems too. With the perineoplastic kind of stuff, there's some cancers that can just trigger that immediately, but most of the time cancer-related DIC comes from sepsis. And then you're going to hear this again with Ms. Ward this summer, because if you have retained placenta, that can trigger the clotting factors, and that can trigger DIC also. So you're going to see this again probably several times with related to OB and when you talk about cardiac kind of stuff too. So and reclotting and all that. So anyway, it's an abnormal activation of the clotting system, and it actually starts with widespread clots in the periphery, and then as the clotting factors are used up in all these different places all through the peripheral areas of the body, then you don't have anything left to prevent bleeding in other places. Like if you have like an aneurysm or something, or if you have any kind of weak spot in your GI tract, if you got an ulcer, I mean, you could just bleed out. Oops, get my thing here. You could have an ulcer and just bleed out. So, or any kind of injury, you could just bleed out. Or if you had to have emergency surgery, what are you going to do? Well, if you had to have emergency surgery, what maybe could you do? It's like platelets and clotting factors. Yeah, they're platelets, because you may want to replace platelets. They may get consumed really quickly, but you really can transfuse platelets. If you can actually give fresh frozen plasma, also that would give people some of the liver clotting factors directly as well. So, and again, you're going to hear more about this. This is not something you have to know in tremendous detail, but anyway, especially gram-negative organisms tend to trigger this clotting cascade, and it can actually sometimes, when you have problems with incompatible blood, then it can trigger the clotting cascade too. And cancer patients get a lot of blood transfusions, so they're at risk in a whole lot of different ways. And so there are a lot of ways that this can happen. And so don't freak out with this. Okay, there we go. I think this isn't really that pretty or anything, but it does sort of tell you how the fibrinolysis, you're getting rid of the fibrins breaking down. And then one way that they can tell that you have DIC is if the fibrins breaking down in the microcirculation to try to get rid of the clots, because it does send a message when you got clotting to try to keep things in balance. And then the circulating fibrin degradation products, you may see the abbreviation FDP, and that's fibrin degradation products. And so that is a signal that there may be some DIC going on if it's really, really high. I mean, you might have some of that anyway, but if it's above normal, then that's a problem. And so this can just tell you what all kinds of things can happen with it. You can have the ischemia, of course, because if you're not perfusing in those areas in the periphery where you have clots, or it can be in organs too. But wherever the clots are, there could be necrosis, and gangrene can set in. And then if it goes into if your kidneys get clogged up, then you're going to have protein in your urine, and you're going to have not much urine output. And pulmonary, you're going to have, well, just it really makes sense. You're not going to have the peristalsis in the GI tract if you've got clots in there. And then if you've got, the thing that's really difficult here is that you've got then clots, and then you got bleeding at the same time. And then so what do you do? Because it's just the opposite kind of thing to treat it. That's why it's so difficult, and it's so potentially fatal. But you really can see the petechiae and ecchymosis and vena punctures are oozing, or blood bleeding from anywhere, possible any orifice. And hemoptysis is coughing up blood, and nosebleeds, and bleeding gums, and then massive bleeding in the GI tract. And so it's really, really a frustrating condition. And I'm sure that they're a lot better at it now than word to begin with, but it's still not a great thing to get. So, and this is the fibrinolysis kind of thing, and you don't have to memorize all that stuff, but it's just sort of good to see the picture and see that that it's being digested and the fibrin clots breaking up, and then there's the fibrin degradation products. They're just like little fragments, and that's where you're going to see that as a blood test, and it will be helpful. But you don't have to remember all of that stuff. I know you're going to get that later too. But and sometimes they call them fibrin split products instead of degradation. So it might be FSP. And then you check for increased PT and PTT and all the time, and fibrinogen levels, all of those kind of things that you can see with bleeding problems. And that's a person with mostly some TPI and things like that. So, and then intravascular thrombosis and perfusion and all of that. Okay, and here's another picture of it. And this is this one's where it's much more detailed and everything, but this is talking about when you have retained placenta or the abruptio placenta. That usually there's some retained, and that's where women can bleed to death if the placenta is starting to come loose but hasn't totally. There's some of it retained, and then. This is giving you some of the areas that can cause it. And what the deal is the therapy is to treat the cause, and that because it's really difficult to treat the DIC. If you can treat the cause, then that can arrest the process. So in some places they will use heparin, and that's still controversial because some people don't want to do heparin if they're bleeding, but then how are you going to keep new clots from forming in the periphery? And but some sources just say you automatically do heparin, but it depends on what facility you're in and what the philosophy is of the healthcare providers. But anyway, fresh frozen plasma, cryoprecipitate, all these RBC and platelet transfusions and everything, those can certainly help. And again, you don't have to memorize this. This is really just for visualization's sake, so you can kind of see what we're talking about. So we want to use, our big thing to know about this is to use aseptic technique for all invasive procedures for every patient. We want to do that for everybody, especially somebody that's progressed and cancer patients. So early detection of infection and early treatment can prevent the DIC, replace the clotting factors, fibrinogen, and platelets. So sometimes it's just simple as doing that in some cases, but the process is certainly not simple. But anyway, the heparin can prevent further clots. Heparin doesn't dissolve clots, does it? It just does what? And it prevents new ones from forming. So it's not going to absorb the clots, because you have to have an enzyme to actually destroy the clot. But then they don't really say using enzymes for this. So and you want to be real careful with invasive procedures. You don't have to. You don't want to do regular temperatures. You don't want to do injections or even sub-Q injections. And if you've got a central line already, you don't want to be doing other sticks and things. Possibly, if you have to have central line, you're going to have to have a place that's fighting back to the central line and limit joint involvement, because joints can bleed. You can bleed into joints and really have some problems with that. And of course, the really aspirin products. And what happened with a patient like this if they get really bad constipation? You know, I'm into rumination and flatulence and all that. Yeah, and what would be like the worst case scenario? What did you say? How to go? Yeah, with that Valsalva, what could you have? Yeah, it could cause heart arrhythmias. It could cause if you've got increased intracranial pressure from pushing down, it could blow a vessel, and it's going to blow really easy if you don't have anything to okay. So spinal cord compression. This is a whole other thing. Jumping. But these are things to look for. Okay, the epidural space could have tumor in there. And I'm trying to remember who had the patient with the tumor in the epidural space. Who is that? It was yours, yeah, that was what I was in high school with. Oh, yes. So, but anyway, he had tumor, and it was supposed to name actually a really part of it, and then they were going to do it. And I never did hear how that turned out. We wasn't there the next time. But anyway, you can have intense localized persistent back pain and motor weakness. Just like what might you see? Like if it's in that dural space in the lumbar area, what might you see is a nerve kind of involvement, or what are we given? What's that? Yeah, like if you may have extreme weakness or extreme paralysis, exactly. And if it's like in the vertebral area or something, then that's a whole lot worse. You may have a whole bunch of from that level down. And of course, without elimination, incontinence and potential and all that kind of stuff. Yeah. So we need to detect it early so that you can remain or maintain the function. And you can treat with radiation therapy or surgical decompression. Depends on what kind of tumor it is, whether radiation will be effective in that situation, or if it's easily accessed surgically too. And we do use steroids to decrease the swelling and the inflammation. And then possibly chemotherapy to treat the underlying cause, especially if it's a fast-growing cancer, then it may respond really quickly to chemotherapy. And then you can use the activate braces to support the spine. But the whole thing is that sometimes you can see this with Brett's vertebrae also. That can certainly impinge on the spine as well. So that can be a real problem. But you do see it in lung and prostate and breast and colon more than as a metastatic tumor. It's not usually a primary tumor. But the thing to remember most about what you need to notice on assessment is if somebody has sudden, tremendous back pain. Because so many, who has never had back pain before? Has anybody ever had it? Yeah, because everybody has some back pain sometimes, right? And some people have it chronically, and they have, we've had so many patients that have multiple back surgeries and stuff, and then they come in and hip, and so they're hurting a lot of times, but they're hurting in their back maybe more than they're hurting in their surgical area. Have you noticed that? If you ask them why they're hurting, you assume it'd be the surgical area, and sometimes it's not. Sometimes it's their chronic problem. But so then there was somebody who says, oh, my back hurts. My back hurts really terrible. And it's like, oh, your back always hurts really terrible. You need to really, really investigate that. Is this different than it was when you took your pain medicine 3 hours ago? Or is this, is this suddenly causing you a lot more problem than it did earlier, or than it ever has before? Because that's what you have to differentiate. And so that's where we miss it sometimes. So that can really, that can make somebody paralyzed if we don't catch it quick enough to get the pressure off of the bone. So the early detection is essential. So that's the big deal. All right. Hypercalcemia. Parathyroid hormone can be secreted by some cancer cells. Even if there's not any cancer in the bone, sometimes there's parathyroid hormone just abnormally secreted. Ectopic hormone secretion. And then, if they're immobile and all, or they're dehydrated, then that can contribute to it or make it worse. And then, if bone metastasis, then certain calcium levels do decrease. In multiple myeloma, it's actually a plasma cell tumor. And it's like the antibodies are not producing properly, but they actually they're not part of the bone, but what they can do is secrete osteoclast activating factors. What do osteoclasts do? Break down bone, right? So and so that's an ectopic secretion too, the osteoclast activating factor. So that's what we see a lot with multiple myeloma. We can see it with breast and lung and other cancers too, and more possibly with other bones. Yeah, what's stomach medicine in called bone fractures? Bone protonics. Well, that one actually
proton pump inhibitor.
Well, which some medicine that we see so much in the hospital, proton pump inhibitors can decrease the calcium and cause, especially in people with osteoporosis and all that. But then if somebody has cancer, and maybe they don't have osteoporosis, but when they have cancer, and then they take a lot of protonics, and that's just one more onslaught to their bone integrity. So that you have to remember that, especially if it's a chronic thing. And I keep telling my clinical students that chronic is really tend to be a temporary kind of thing. There are some people that can have a lot of erosion of their esophagus, and it's really, really susceptible to hemorrhage, because this area is very vascular, and especially some of the alcoholic and esophageal varices and all that kind of stuff, then it's really, really important to protect it. And sometimes it is worth it to go ahead and use proton pump inhibitor chronically, and it can really be a lifesaver for those people. But you know, we need to be judicious about advising our patients to see if there may be something else that they can do besides proton pump inhibitors to relieve their symptoms. And I think they're sometimes just afraid to go off of it, and we can risk that sort of thing. Anyway, let's see. All right, so hypercalcemia symptoms, they start just not caring or just feeling depressed, fatigue, muscle weakness, going to the bathroom a lot, because when you got a lot of calcium going through your kidneys, it's water and everything too. So, and then you just don't feel hungry, and nausea and vomiting. Sometimes the biggest symptom has been when we see patients with that is actually nausea and vomiting. And so, what drug is it? And so it's really hard to determine it sometimes. And we had some patients that were confused before we knew that they, especially multiple myeloma patients, were really just not quite right. And we did have one lady come in and was throwing up, and she wasn't really taking anything like chemo or anything that would have made her throw up. I mean, she could have a virus or something, but Dr. Blake said, yeah, let's just check her for calcium, because this is just her disease is, that's, I think it was myeloma that she had, and so sure enough, she was just hypercalcemia. We had a man coming in who was just real confused, and he had not been that way before, and so we checked calcium on him, and sure enough, calcium too. Sometimes we do it preventively with medications people that have myeloma in particular, to strengthen their bones and to prevent the calcium from leaching out. And it does prove with phosphorus rather than trying to add calcium. But then in that case, that does make them have hypocalcemia. So, but that new one that is the monoclonal antibody. That's a different kind of drug, and that's not going to cause the hypercalcemia. But it is just very, very expensive too, and so that's not necessarily the standard of care. I think more people are still using the bisphosphonate, glutamate, or glutamic acid. And sometimes when you get the calcium out by getting medication, they used to have some chemotherapy drugs, lysis, could decrease calcium. It's got some chemo side effects like limits of counts, so I guess you don't want to use that if you've got something better. But if you just can't get it out with medication, you might have to do some emergency dialysis work temporarily until you can get it to a workable level. Okay. So syndrome of inappropriate ADH. We talked about ADH some in our urinary unit, didn't we? And we're talking about the loop of Hindley and the descending and ascending tubules and proximal and the distal and all that kind of stuff. So where's the ADH that you're working on? Somebody say it loud. Distal, yeah. Yeah, that's the distal. This is another paraneoplastic thing. It's an ectopic, and that word, abnormal. So antidiuretic hormone, does it make you get rid of more fluid or make you retain fluid? Hold on to it, exactly. And y'all had that in fluid electrolytes some too, didn't you? So you're going to keep hearing about all this, I think. But anyway, some cancer cells can actually produce it themselves or store it or secrete it or either cause the body to hold on to water more. So anyway, you don't have to memorize which cancers cause what. This is just a video of those kind of facts. That's not really that helpful. It's like, if this is happening, what are you going to do about it? That's what I want you to know. So anyway, the big thing is the problem's not sodium deficiency. It is what?
Excess
water. You got too much water. Exactly. But we do have a sodium deficiency, though, don't we? So the more sodium is excreted, and you can have the hyponatremia from like 115 to 120. It can be even less than that. And so when you don't have enough sodium, what happens? Yeah, it really messes with the brain, and it can mess with your muscles too, because it's a neurotransmitter, and that means electrolyte is a neurotransmitter, so it can mess with any of your muscles. But when we talk about calcium, it's even more heart muscle issues, and just all muscles hang on to the sodium channels for function and so. And then the CNS changes are what a lot of times we see with this. And the seizures and coma and death can happen if you don't get them treated. So you want to treat the cause, but you can do something about the ADH as well. But we want to do radiation or chemo to try to keep it from increasing or keeping the tumor in size, and then monitor the sodium response. And so just remember, it's not a sodium deficiency. It's actually intoxicating. A lot of the cells are intoxicated with water. So what you're going to see, what you want to look for is a bounding pulse and neck vein distension, and crackles on the breast cells, and increased peripheral edema, and decrease urine output. And I think did I get that in y'all's? Okay. I knew I wrote it down, but I hope I typed it in. Okay. And then pulmonary edema can have a rapid onset and can be rapidly fatal. So that's not a good thing. And you definitely need to do really, really strict measuring of what? I know, yeah, what's going in and what's coming out. Our treatment can be a loop diuretic to help you get some of the water, because that's working in a different place than where the ADH is working. So the loop diuretic makes sense. The lysis or vena, to cover some of the units. Generic is something but you're going to get hypertonic saline. And some of y'all have done the PESI, haven't you? Maybe some of y'all sent that to me. And did you think that was a good explanation? I think it's wonderful. I really think that's a wonderful way to understand it. And then put a face on it, because it shows you a little person that's having problems and what you do about it. But treating with what kind of saline are you going to use? Yeah. So you're going to get it into the vascular space that way.
Have we did it
Here's an old MRI. That's a side effect. You can use it for a lot of things at all. It is something that it's a new use for an old drug sort of thing. So that can certainly be given to treat it. So, all right. Gosh, I just didn't remember that this many of these things. It's a lot, isn't it? Whew. Okay. Tumor lysis. Hyperuricemia. And this is triggered by chemotherapy or radiation therapy sometimes working too well. It kills so many cells at one time. So when cells just blow up and need to be, the byproducts need to be taken care of, what are you going to have? Like, what are your nucleic acids? The purines, yes, exactly, purines. And then if you've got all these purines floating around, your liver is going to want to make what out of them? Uric acid, yeah. And so then the uric acid
gets into the kidneys, and it's a whole lot of it coming at one time. If a whole lot of cells die at one time, and then it crystallizes. Well, acid, you've seen like acid crystals probably before, the acidic kind of things that can crystallize if they're not dilute enough. And so it could crystallize in the kidneys and then just block any of that filtration that needs to go on. So they can mess with your electrolytes tremendously. So these are things you've got to remember. This is very, very important to remember this. The hyperuricemia, the uric acid in the blood. And then you've got phosphorus as well, hyperphosphatemia, hyperkalemia, and hypocalcemia. And we talked about those being the opposites. And what is the biggest intracellular electrolyte? It's potassium, right? So you bust open a whole bunch of cells and you got loads of potassium in there. And what can we see if we've got hyperkalemia? What we got to worry about with that? Heart. Yeah, and phosphorus isn't so great for the kidneys either. I mean, all this stuff is really, really dangerous. So, anyway, there's the cardiac malfunction. Okay. And we call it, if there's a bulky disease where there's lots and lots and lots of tumor cells that are mitotic kind of stage, like small cell carcinoma of the lung, or very rapidly dividing cells in acute leukemia, or some lymphomas that grow really quickly. Some lymphomas are slow growing, but there are some that are very aggressive and have high mitotic index too. And multiple myeloma a lot of times can do this as well. Then chemoradiation can work too well and destroy so much in one time. And again, this is not something you can memorize. This is just for illustration only. But you got the cell with all these K's in here, and then you've got all this is your nucleic acid stuff in the nucleus, and then you get your treatment, and then you got all this stuff popping out of these broken up cells. And then you're going to have tall T waves, flat P waves, bradycardia, GI hypermotility, all this kind of stuff. And you don't have to memorize that part because you're going to get that later too, probably. You may have that in through the electrolytes, did you? About what you can have with the hyperkalemia. You don't have to memorize that. If you want to, you can, but I'm not going to ask you that exactly. That's not really just realizing it can mess with your heart. And then this talks about the liver production of uric acid, hyperuricemia, and precipitation of the uric acid into the renal tubules, and then you can have the acute renal failure. So that's just another visualization for that. Okay, and the big thing that we need to do is prevent it. And we know that somebody's got some really fast-growing cells. We have a lot better ways to tell which cells have high mitotic index now, and we know that acute leukemia does, and that small cell carcinoma of the lung does. And so you want to be just very, very careful with that. Keep people very well hydrated while they're doing their treatment. That's the major. But sometimes these people don't feel very well, and you think they're going to always drip like liquid before they come in. They're not. So I think with some hydration, dehydration going with the treatment, if they've not been able to drink enough fluid, they have to do, we'd say, like 2 to 3 liters. But one of the sources I was looking at, I think it was set up to 5,000 mLs if it's at all possible. But some people's hearts can't take that either. So you've got to really balance between what other pre-existing conditions they have. It would be great if you could give them all 5,000 mLs, but that's not necessarily going to suit everybody's system. So anyway, aggressive hydration, and then alkalinize the urine. You can use baking soda tablets. They actually have like aspirins that you can. I think you actually did as a chemical do it for a prescription for it, so patients have understand how to take it. You really could do it in teaspoons and all, and you won't know people can measure them. Tablespoon or whatever, if you say teaspoon, then not measure it quite right. So, but you want to have the alkalinization of urine because we know that that acidification is going to happen, right? If we don't take care of that. And we want to add the diuretics and allopurinol to increase the excretion of the purines, the uric acid, as you would for gout. I mean, that's what we see in joints when we have gout. So, and then if they have potassium, they might have to give
There's a new one called raspberase that is an enzyme that actually breaks down uric acid and helps prevent the production of uric acid as well. So it really is more effective than allopurinol. It is just extremely expensive, and not everybody can just go as an outpatient and go to their drugstore and just buy a supply of raspberase. It's RASBURICASE. And I put it FEBUXASTAT also. I don't know, but that's not, you don't have to memorize that one necessarily, but there is a new enzyme kind of treatment that really is more it's newer, and it's not necessarily the standard of care. It probably gets really better, just like some of these anticoagulants that you don't have to do so many blood tests with and don't interact with so many other drugs. But you know, economics is that's a big factor in a lot of these cases. And usually allopurinol and allopurinization is still the standard of care. Some people have enzyme treatment as well, so it's not as important to remember that particular name, but just know that there are some new things coming out that may be a little more efficient. So, but we do want to do prevention. That's our biggie. And so the hydration and the decrease in the uric acid concentration is the goal. So hydration, uric acid, and then they may need to have some diuretics to really be able to handle all of to handle all the fluid that they have to have. All right, God, we're about tired of talking. We got to get some water. Let's take it to yeah, this one's hard just to read on here, I guess, but it's kind of pretty anyway. Margot McCaffrey, you've probably seen that with the chapter with Hypercalcemia, that she's the author of philosophy and research. She's a nurse, but she's a PhD, and she's like the fellow of family nursing and all this kind of stuff. So she really knows what she's doing. So pain is whatever a person says it is, existing whenever he says it does. And we all know that we end up having patients in the hospital that are probably coming in and out, and they're like boomerangs because they want their Dilaudid or they want their morphine and all this kind of stuff. So I'm not going to try to do all the judgment calls on that sort of thing. We're going to try to relate everything to cancer. I had y'all read that whole chapter. Sort of acts like when we were doing the introduction to cellular regulation. Before we actually got to the taking care of people with impaired cellular regulation, they had an introductory chapter with explanation of how cells are supposed to work, and then we talk about how they go wrong and the carcinogenesis and everything. That chapter is really a background. It's not like you've got to memorize everything in that chapter, but I do want you to read it. I think anybody that's going to be given pain medications for surgery or whatever it is, that you need to have read that chapter, because I understand y'all didn't have that assigned specifically in Ms. Ward's class, because you were really focusing on physical assessment and how to assess pain with the location with it. Y'all learned about the colder and all that kind of thing, all the things that you need to ask about pain. But this went into a whole lot more depth. It's so good for any nurse, I think, to read about pain occasionally anyway, even if you've been in a long time. Because every time I read about the pain content and stuff, it's like, I just, oh gosh, yes, I have to think about that in this situation or whatever, and tell students such as that. But anyway, it's very important to have that background. So I'm not going to go over all of that stuff, but it's not that it isn't important. They really, really, really need to read it to have a comprehensive understanding of what we're talking about right here. So, okay, we need to believe what they say, and that's what Ms. Ward told y'all, that that's a subjective. The pain's a subjective symptom, really, or nursing diagnosis or whatever, or a psychosocial nursing diagnosis. I do let my students use pain if we know what the cause is, because sometimes you don't. Sometimes pain can be a problem in itself, but if you know what the cause is, then you know how to use it as a physiological, because it can't really separate it. It's a physiological sensation. But anyway, that's not really relevant. But I think we have to realize that our bodies and our minds and all that, they're connected, and we can't separate them. And so we've got to realize that everybody's a holistic person, and it's not just psychosocial on one side and physiological on the other. We're all together there. So they certainly affect each other. Okay, and we've heard about the fifth vital sign. I'm sure y'all talked about that. But nurses are legally and ethically responsible for adequate pain relief for patients, and that's why we always have to go in and check on that. And that's been not legislated, but well, I guess it is. You are responsible for assessing and taking care of people's pain. That's why the students sometimes if they're writing a note or something and saying, hey, just got 8 out of 10 pain, then what did you do? Did you take a nurse? Did you give some pain medicine? Did you got to do something about it if the patient is uncomfortable. So even if it's positioning, even if it's playing them song or telling them a joke and making them laugh and getting their own endorphins going so that they have some of that morphine-like sensation. I don't know how I told y'all this last semester, but I was really stressed at work, and when Saturday that third Austin Powers movie was coming out, and I thought Austin Powers was the worst thing I ever saw, and I couldn't believe my sister was late for children's. Little children watch that.
Run.
Sometimes you just need those endorphins, and laughing can certainly do it. So that's why it's really important to use some humor with your patients. Sometimes, if it's appropriate, of course, it needs to be appropriate. But that can really we really did have lots and lots of humor in our office when we have patients there for a long time. And depending on the patient, of course, whether they need to laugh or not. But they initiated it a lot of times. Some of the patient initiates it. Why not play along? It's going to feel better. It's not something nasty or something. We want to do that. Okay. Anyway, I'm not going to go through all of this etiology and all this and cue the client. I think already know some of that stuff. And the gate control theory is something that's probably something they're going to want you to be aware of that for NCLEX and all that. You can't guarantee what you're going to get on NCLEX, but I think that's something that they're going to know. They want to know that you know that. And you're probably going to see that on a lot of capital stuff too. So, and it's on pages 43 and 44, and then it has a picture of how it works. But then when the endorphins are released, if you close the gate of pain transmission, you block the pain perception, and it has explains how the non-verbal interventions can help with the pain control regimen like distraction and joking around and singing, whatever it is that it gives. Or sometimes touch. That's certainly that can close the gate sometimes if you're holding somebody's hand. So, or even maybe a hug. Again, you just got to decide if that's appropriate or not. We do lots of hugging in our when we were in our office, and you don't always automatically start doing that. You got to have a relationship established before you do that, and that's always a little. It's a little awkward to make that decision because some people could take it the wrong way, or if they're saying the sexual harassment, the wrong way overboard. That can be so important to people feeling cared about, and some people you really do have to make that judgment, or you can even ask them, can I give you a hug? And if they say no, I'd rather not, then no. But I don't always do that. I pretty much get impulsive about the hugging business. But anyway, but then I do have some people or some situations where I'd rather some people not be in my bubble either. So you do have to make your get this understanding in between before you do the sexual harassment business. And I think you have to think about that. would be loving and caring for their system. Okay, well anyway, we do have barriers to adequate pain relief. Sometimes people don't want to complain. I haven't really said this that much to my clinical students this year, but I had a nursing instructor that, oh gosh, I was so scared to death. I told you right before my evaluation for clinical, we did get graded on clinical, and my stomach hurt so bad. I really thought that I was going to have to go to the hospital. And after I went and did my evaluation, because it was so stressful going to talk to her. She was scary. Oh my gosh! And she wasn't really mean, but but if you went and wrote anything on your plan of care or data collection or assessment stuff, it said chief complaint or patient complains of this, patient complains of that. She big old X on that. No, you do not say patient complains. The patient states. The patient reports. You don't say that word complaint because that has a connotation of somebody being whiny and uncooperative and that they're not a good patient because they're complaining and they're whining. I don't want to see that. Do not want to see that word complaint. Do not put that on there. And I made somebody yesterday. Who was it yesterday that had to put the comment on there? That was Karen one. It said patient refused. Patient will refuse her regular, and that's what they wrote on the bar before we ever asked her. And we did ask her, and she declined. I said, just put decline. Because refuse makes it sound like you're being afraid. I'm so sorry to be on that. I really think there's something to it. Decline makes it sound like you're being invited to the party or something. Anyway, that it does say that good patients don't complain. And that it's inevitable with aging. I'm just this age, so I should hurt. That's just the way it is. You just hurt when you're old. Or you don't want to have shots. Side effects can be worse than the pain. And we see that with surgical patients. And that they just don't, they don't want to have that weird feeling when they don't feel like they're in control. Because it does cause a level of consciousness for them. And they don't feel safe. They're not feeling they can make good decisions. And they'd rather hurt than feel like that. And sometimes maybe we can ask the doctor to change it and see if there's another way that doesn't affect them in the same way. So, but they're afraid of addiction, and that strong medicine is only for people that are dying. Or if you're giving me morphine, I must be dying then, and it can be very scary for some people. And then that some providers, this is where it's really sad that they're better judges of the pain than the client is, and that the pain shouldn't get the highest priority, and that only use opioids for severe pain, and they're reluctant because of the risk of respiratory depression, especially in dying patients. I read Sam's last week when we were talking about the nurse that they kind of pushed the morphine and died.
Oh, yeah.
And
she felt like they were going to die.
And so she was just sort of anticipated that. But yeah, you responded to some of my students or something, and I just happened to see that. See what he's talking about. But yeah, it is kind of scary. But you're not giving it to the patient to make them die faster. You're giving it to them to relieve the pain. If you're giving it to them for the indicated FDA-approved indication for use of that medication, you are not, trying to kill the patient. If you're doing it in the dosage that's ordered and all that, you have to really change your attitude on that for especially end of life patients, and that's what your patient was. What you're talking about. We fear harm in the patient, and people don't understand the addiction situation, tolerance, and dependence. I just like to talk about the World Health Organization approach, but just in case that I think it's a good thing to just be aware that the World Health Organization does have a recommendation that you start with non-opioids if possible for cancer pain. This is not necessarily for surgical. With or without a co-analgesic like an NSAID or anticonvulsant or antidepressant, but it's usually an NSAID or like Tylenol. And if it persists and it's for moderate pain, then you go to a weak opioid like we used to use Darvon, but that's not too many like some heart issues.
then if it's severe, then you do the strong opiates and titrate it around the clock schedule doses instead of waiting until they hurt. Just go on and do the around the clock doses to keep a steady level. Or you can certainly use the long acting so that you have a steady basal level, and then if you have breakthrough pain from that basal level, you can turn and twist wrong in there or something like that, or if you have to get up and walk rather than lie down or sit in. You do physical therapy like you do for surgery patients. Okay, so our types of medicines that we use for pain relief, the Tylenol and the NSAIDs, non-narcotics and opiates. And then I put that Narcan on there. It's the antidote for overdose, and it does compete with the opioids at the receptor sites in the CNS. So that's how it works. That's just, I want y'all to know that, because that may be a reflex-like question too. Why does Narcan reverse it? Because it's competing with opioids for the receptor sites. And we use antidepressants and convulsants and things like that. And sometimes with pain drugs, and lidocaine patches and vaccines, back pain patients will always need lidocaine patches. You do it for 12 hours and leave it off for 12 hours and then apply it again the next day, because it's a transdermal kind of system. So you can sometimes use like Flexeril, with some of the other ones are Scalaxin, I think. That's a muscle relaxant. And then other pain treatments, especially like my aunt has breast cancer metastasized to the hip, and really it's actually both of us. The one arm hurts worse than the other. She's had some radiation therapy too before, but it's for again, so for some more. It only takes so much in the area, but the bones really can take a lot more than ordinary skin. So you can use radiation therapy on reducing pain with bone metastasis, or to shrink tumors that are pressing on organs or nerves or causing pain. So, and then you can do injection of analgesics into the spinal cord or nerve plexuses, like doing epidurals, and you can do some surgical severing of nerves. That's sort of a last resort, but sometimes they actually do sever the nerves, and do some kind of block on medications, which you can also do the surgical severing if it just doesn't work. Okay, and if you possibly can, start with the oral route. Well, cancer patients, that's not necessarily surgical. Just remember that this is what we're talking about. For chronic pain, they're probably going to have to be on pain medicine for the rest of their life. Start with oral if at all possible, and non-narcotics if at all possible. Now, some people can't take this, like Celebrex or Arudis, I mean, some of those strong NSAIDs, because of well, why would they not be able to take them? What are some of the kidneys, right? It can bother some people's kidneys, exactly. And so if you don't have good kidney function, that's not really a great choice. Yes, gastric irritation, and it also it irritates. But what else can it do to the stomach? GI bleed, but other bleeding too. It really does decrease the platelet function somewhat. Not exactly like aspirin does, but it does all those other things except for tamponade to do that. So we can combine with steroids, antidepressants, anticonvulsants to achieve the maximum pain relief balanced with optimal mental and physical functioning. So it will help you decrease some of the opioid side effects that you would have if you had to keep on adding to the dose of the opioid that would cause more and more constipation and all that kind of thing. But I know that table 5-7 on pages 55 and 56, roots of analgesics. I think that's really a good thing for y'all to look through. And you probably know a lot of that already, but I think it's so good to just beef up on the fly. What are the advantages? What are the disadvantages? And that's something where nurses can really try to collaborate with physicians, especially in the life care and things like that. But we just say, why can't we try this? See, or what do you think about? suggestion is when you're doing that SLR kind of communication, the recommendation will be, well, you know, I've read such and such, what do you think about trying this on this patient? That's where nurses can really be helpful, especially when hospice nurses are really trained to do that. But you know, other oncology nurses, and then if you have an oncology patient that a general practitioner is taking care of for some things and getting some medicine or anything, then that's even more reason to know about pain really yourself as a nurse. We maybe suggest what you want to know where it's in your book now. I think that's such a great resource, especially when we have a patient that's got chronic pain. Okay, neuropathic pain, that's a whole different animal. So you can give all of this opioid dose, you can keep going up and up and up and up over morphine, and you may not ever relieve neuropathic pain. So what do we do with that? Yeah, was it Neurontin or Lyrica? Either one of those, because they have the gabapentin and pre-GABA. You never had GABA in it. Yeah, pre-GABA and GABA. And then you can actually use just SSRIs, but they're saying that SNRIs are better. So what are that? What's the N? Norepinephrine. You know, we've had some patients that have been taking some of the norepinephrine reuptake inhibitors as well, or it's both serotonin and norepinephrine, and those are Effexor and Cymbalta. But you know, sometimes you'll see Prozac or there's any of the other ones as well that could help. But the ones that have the give you the norepinephrine and the serotonin reuptake inhibition can be super charged. And we also can use some other anticonvulsants sometimes. It doesn't have to just be, you just really do see the Neurontin and the Lyrica, in especially like diabetic neuropathy and fibromyalgia. But for the neuropathic pain you can have neuropathic pain from chemotherapy. There are a number of drugs that can cause neurotoxicity, and it can really hurt like diabetic neuropathy. So that we can treat that kind of a side effect of, and if you have some nerve problems from radiation therapy, like radiation, that can happen as well. And really treatment related, not just the cancer itself. Okay, so what's tolerance? Yeah, the same dose doesn't work anymore. Your body just needs more of the medicine to have the same effect as it used to. Your body needs to, and that's not addiction, though, is it? It can lead to it in people that take drugs recreationally, of course, but that's not necessarily. It is just a physiologic phenomenon. It happens to anybody that takes opiates for a long time. So, and it is when you have dependence. That's a biological substance. And then you can have, but you can't have physical withdrawal if you stop taking something. So, and then psychological dependence is that you just want to take it because you want to feel good, you want to have the buzz. So if the substance isn't supplied, the psychological withdrawal symptoms occur, and as well as if you've been taking a long time, of course, the physiological will too. So, so what are some of your side effects from the opioids? That was the worst symptom we saw from our patients. So much constipation. We were working on constipation. That's just really bad. And you'll see that even in surgical patients that have been on it just for days, and it was miserable. It just absolutely miserable. They really can't go. So major issue, especially if you've got low platelets and they have to bear down and all that. I always keep reminding you of that. It's not giving somebody a laxative can be a major intervention. It's not just oh well, let's wait and do that tomorrow. You know, it can be very important to keep those valves moving for a lot of reasons, especially when it's severe and potentially also just totally stop. And we've seen this progression, you know, about respiratory depression. I think we've already kind of covered that in other courses, but we just have to be reminded of that. Okay, strategies for chronic or constant pain. We're going to use the long-acting oral, and preferably oral, but sometimes we use the patches. You know, that's a convenient thing, but what's another reason besides like convenience to have it long-acting, which might use the patches instead of pills?
Yeah.
In outpatients, anybody see a colleague having pills around the house?
Little chip.
Because people, we have so many patients that people would, like, their grandchild would come over to visit and bring a friend, and their grandchild would be scoping out the house. Oh, I'm going to an old person's house. Maybe they'll have some pain medicine. They know exactly what they're looking for, and they will take it. And sometimes with the patches, they don't really put. And people have learned all this stuff. Eat up the patches.
I'm so glad you could have raised them over them. I would never remove it. Eat them.
Well, if you look up the crocodile thing, there's a scholar who's put it out in the hall. Maybe that's what they call it. But anyway, it's sometimes we would give people patches just because it's not as obvious that the patient's got pain medicine in the house, and it is just you know, that people know what they're looking for, and that's a shame, but you know that. And sometimes we have had patients that their children would call all these different pharmacies or all these different doctors, and all of them would call them to different pharmacies or give a prescription. Then they go on to Spinal or something or in Finland, and then they sit at the gas station and take person and all this stuff. That's what's terrible. People that abuse the system make it so hard on people that really have problems. That's just the way it works in our society. And I wish we could figure that out. And I don't think we ought to have all those people taking up so much room in the jail. We need to do something about it. I don't know what the answer is, but it's just not right that we have to have such. We make it so hard on people that really the dog did eat it, or not eat it, but the dog maybe not in the toilet, or you know. Because sometimes that really does happen. Questions like sometimes there's just have to have the bottle open and not in the toilet and all else. It's easy to do that. It's just not really fair that people really need to have to be questioned about stuff. So anyway, we can use the short-acting rescue medicines for the breakthrough pain. You don't just have the long-acting. You do have to have something for the breakthrough because there's always something that's going to elicit, you know, a greater pain. If you want to have that baseline of relief to keep having the spikes up and down, so you're taking it every 4 hours kind of stuff. But you still need to have some of the short-acting. And the thing that people don't understand sometimes is that if somebody's having acute pain and it's time for the long-acting patch to be replaced, or have an S-Contin or something like that, OxyContin, and that is continuous release. If you see Contin or SR or ER, extended release, all of that means that you don't want to crush it, and that it is going to be a long-acting one. But if they're due for their long-acting, like morphine or OxyContin or whatever, and they're having acute pain, you really need to give them the breakthrough medicine too, because that's not
that's just a real slow, steady release. It's not going to relieve their acute pain. So you didn't need to give both of them at the same time if they're working. Anyway, we do use morphine a lot of times. I think you saw that in the light part maybe about the using morphine for terminally ill clients with dyspnea, and they're not able to take other treatment to be able to rectify their condition. They can't get their airways clear by taking more radiation or anything like that. And so when you give morphine, it actually does it reduces sensation of restlessness or dyspnea, and it's not so desperate. And it also does dilate the pulmonary vessels from feeling so congested. And that's what really is actually SAM patients trying to reduce their sense of recklessness so it's not so miserable and having to make decisions for every breath. And again, if you're giving it for the comfort, then that is an improved reason to use morphine, and that is difficult for some people to do. Like Sam's nurse was worried about it and everything, but you're after a good death. Not something that's really difficult. Okay, let's go to Tylenol. I think I'm going to have to just post it. I wish I had time to do a work. I got a short about Tylenol and how dangerous it can be with being in combination with other medications. Some people are taking in combination with cold and fever kind of things, or some that maybe with Benadryl and Tylenol combination and get some to sleep, and then you can really know there've been lots and lots of overdoses of Tylenol, and it's very, very dangerous to what organs? Liver, yes, definitely. And it can have some effect too on the kidneys, but it's more so than the liver. And the other NSAIDs are more so with the kidneys, but they have to do with the liver too, so if you don't want to give too much. But if you've got a healthy liver, 4 grams is the absolute max. But most people that are taking it are sick and they're not healthy, so they don't need to be taking any 4 grams. So when we have this Tylenol 500 milligram Tylenol tablets, you couldn't even get 325 milligrams much in the grocery store or anywhere, or in the drugstore or whatever, in the 500 milligram extra strength. And it says take every 4 to 6 hours. And so when people are hurting, what are they going to do? They're going to take it every 4 hours, right? If you take 2 500 milligram tablets every 4 hours, how many grams is that?
1,000.
So what's 24 divided by 4?
6.
So 6 grams, and that's so that when you take it every 4 hours, you're going to take 6 grams, which is 2 grams over the maximum any healthy person. And then people that are sick are taking that, and I mean that's really serious. I just want you to realize that. And so now they're really recommending 3,600 if it's long-term use, and then 2,400 if it's shoot, I hit it this thing here. I'm going to have to fix it. But anyway, just be aware that you do a lot of teaching about that, and that's what the little video that I had. I'll try to post that for you if y'all are interested. Okay. Oh, and there's no ceiling level on the analgesics from opioids. You can keep it increasing opioids as long as you want to, as long as they have a tolerance to it. You don't want to start with a dose. Of course, you start with the lowest dose that works, but there's not any common dose that you can so you can steadily increase it. The next daily doses, but you can slow it down that peristalsis and all that. So you don't want to increase the dose of the respirations or 8 or less, unless they're in the blood here. That's a whole different thing. But there certainly is a ceiling for NSAIDs. Tylenol in particular, but in other NSAIDs too, they can cause cardiac problems. So anyway, I'm going to let you can just look at this about the CAM kind of thing, the raking and therapeutic touch. I thought raking very much. I just like it.
tender spots or something, you're going to have back problems. That's a condition that you're going to have.
He want me to do his hand. And then sometimes I got vitamin lotions in his breath.
That was not a
Sometimes it has to
I guess it does for some people. But it can be one of those gate control things. This looks so, I just love this. But acupuncture is something being used a lot more now. And some insurance companies are paid for some of this can. Complementary and alternative medicine. And it can relieve hot flashes that are not that you can't find any pharmacologic treatment that's not more dangerous and all. And then you got to make sure that the practitioners are using sterile techniques. That it's a reputable person. Okay, and this is we need to avoid antioxidants and other natural health products during conventional cancer treatment because I think I told you this before that chemotherapy and radiation therapy work causing oxidation of the cells. And antioxidants, then if those antioxidants really do work, then you're interfering with the radiation and the chemotherapy effect. So you need to wait until after the therapy is done before you take the antioxidant treatment again. You don't want to block. All right, let's go to end of life. I love this picture with the little girl touching the forward of that. Anyway, this is just talking about where you can have deaths and lots of different places. And it is a dying person's bill of rights. Did I get that link on there for a while? Yes. That was I think I put it on those slides. Okay. And we do have legal and ethical issues, and we did talk about advanced directives. I guess we know we're with Ms. Chandler at the very beginning. That's never the most fun unit to have with all that legal stuff. But it is really important when you get to these kind of situations. You need to have health care surrogate or something. It's really good to plan before you get terminal. You don't know when something like happens to you that you're terminal, or nobody's going to know your wish. So then you want your surrogate to know what your wishes are and to help them make those decisions when your health status changes that they're going to have to take over. They're going to have a lot more confidence in making decisions if they know what you want. So, and then the do not resuscitate orders. And what they're doing now is say an AND for allow natural death. They're saying that especially in children because it's so difficult to say do not resuscitate the child or whatever, but allow natural death does sound, I guess that's a euphemism, they make it sound good. It's the same thing really, but you just listen. So sounds a little bit there's a DNR. Then we still have DNR around here, I think. So and it is but then they've made so many conditions with like living wills and all. You have to really read them carefully to know whether people want to withdraw living wills and all that sort of thing. So, and did I put that thing about caringinfo.org, National Hospice and Palliative Care Organization? Did I put that on your sheet? Okay. Because they have, you don't have to get legal consultation to get those kinds of forms. You can actually print them out yourself and fill them out and take them to the hospital. And fitness, you don't want to have somebody that's a computer on you to get nurses and doctors are not supposed to sign and do something like you can do consents for surgery and stuff like that. But at least living wills and not resuscitate, there needs to be a witness that's not within the family anyway. There's somebody who works in the hospital that's not a health care provider can do that sometimes too. Anyway, the euthanasia, they talk about that in Table 9-3 on page 119, where you do painless or easy or good death. It signifies a killing that's prompted by humanitarian motives. In Oregon, Washington, you have physician-assisted suicide in some situations. But then, as far as nurses, ANA, American Nurse Association ethics, and nurses should not participate or actually do the help with assisted suicide. And even in Washington, Oregon, where the DNA doesn't recommend nurses deal with that. I don't know how the nurses handle that, but that's what the book said anyway. And we don't want to be doing slow codes. That's what doctors would say a lot of times. Oh, well, just easily pump on the chest. I had that when I first got out of it. When I first got married, I was not right out of school, but so when I was in my senior year, the doctors need to start something. He's like, what the heck is happening? You know, and then somebody's mad one way or the other. You didn't make him live, and you didn't want him to die easy either. And so then somebody's going to be mad, and sometimes families could file lawsuits and stuff in that situation. I know a nurse that worked with me that ended up being in a lawsuit because of that, because the doctor was not clear on what was supposed to happen. And so I think she actually did do some resuscitation, and the family didn't want it, but the doctor just said do a slow code. And so, but the doctor got off scot-free, and the nurse is the one that suffered for it. And it was terrible. So I'm glad they're making it more strict now. Anyway, we did have all the healthcare agencies have to ask about the information on the X-rays and admission to that. And just asking if they work like one year, and if they do have it, can they make sure to get it on their record so that that facility can help to fulfill their wishes of what happens. You don't know what's going to happen when you go into a healthcare facility, especially surgery. It does say on anesthesia, in consent forms that you know, death is one of the things that can happen with you under anesthesia. So, it says that the data says there's a high degree of symptom distress in hospitalized clients when they're in long-term care clients when they're dying in a facility rather than dying at home or in an in-house hospice. And it's really because they're on their own turf and they don't have much control over what's done to them and for them, and their surroundings are just not you know, what they're used to, and they may not like the fact that they're never going to be able to see their dog again or whatever. So anyway, did I skip my? Yeah. So the palliative care improves quality of life for the clients and families. Our other book made a big distinction between hospice and palliative care. Everybody was similar to the question on the test, how am I going to know if it's hospice or palliative care? Well, the big thing is both of them in your book say quality of life, don't they? It's just the difference is, well, what is the difference between palliative care and hospice? Yeah, the 6 months thing. If they don't meet the 6 months expectation of their lifetime, then they can go into palliative care. Some people can have real serious illnesses that could easily lead to death, but you don't really know if they're going to be 6 months or less. They could recover. You really could anticipate some positive outcome, but you still want to relieve their symptoms, and so and you want to cover the holistic. That's really the big difference. But I'm not going to ask you that. That doesn't really matter, you know, except for the 6 month thing. As long as you know that that's the criteria for hospice. That's really all that differentiating. But anyway, that's. Palliative care can take place across all stages. I remember Nathan's patient switched from acute care, and then the next day was palliative care. It was a whole different set of orders, and everything was different. That was just a big change for your patient. He was in bad shape. He was all confused and all that kind of thing, and then they put him on a lot of the morphine pump, and then he was just pretty much. I know, but he was very restless and uncomfortable, and that was really the right thing to do. But you know, that first day was very stressful while I was trying to work things out with him and decide whether he needed one-on-one care and all that. So anyway, hospice care is in the last phase of incurable disease, so they live fully and comfortably as possible. It can be in life care, can be at home, or long-term care in a hospital, and there is hospice Medicare for those with Medicare. Hospice Medicare is so wonderful. it does cover a lot of things. And I know they do try to save money and use the cheapest brand of drugs, just like hospitals do and all that sort of thing, but it really is so much better than just regular insurance kind of coverage or regular Medicare. They really provide lots and lots of devices that people need or equipment and anything like that, and of course the home hospice, the nurses and the aides come in and help and all that. So this is really wonderful. And what you're after is quality of life and a peaceful death. The quality of life is that lots of people vote for it. And like I can't say this before, but it's about how we live. It's the motto for the hospice and palliative care in Harris County at one time. I guess that still is. Because I think that's great. We want people to live as fully as they can until they actually die, and it's not like a giving up. You're just accepting that there's only a certain length of time left, and we're going to make things as good as they can be during that particular time. So, and we do have to think about cultural, because not everybody looks at death the same way, and they're taking a lot of data about like access to and there are end-of-life rituals for certain religious groups, and that's in your book, page 116, and in the life sections, page 9-2. And they have collected data saying that minorities are less likely to receive appropriate pain management during the end of life. And that religious customs are real important to a lot of dying patients, and some people get more afraid as death draws near, and some people get more at peace. You just don't know. It's going to be a very different experience for every person. I'm taking the answer. I'm going to change it for a walk around anymore here. But we need to individualize the care for the culture, and make sure that we're not handling the body inappropriately for the particular religious customs, and find out about that, especially if somebody is on palliative or hospice care. And in the psychosocial management section on pages 102 and 118, we talk a lot about grief and mourning and spirituality and culture and communication and all that. I think y'all know a lot of that, but and you get a lot of the site content too. But we'll read through that. I think it's, and I love it as a reading assignment anyway, but that's real important. And I think too, I like the way that they say that bereavement is a combination of grief and mourning, and that the grief is the emotional reaction, and then that mourning is the outward display of how you handle the death. So I think that's pretty interesting. Okay, and then our end-of-life care for children. That's so difficult for some people. What is difficult? Children are just die, you know. The rest of my life, we expect to die first before children. But sometimes there can be a lot of adult denial, and sometimes the family doesn't get enough of the hospice care or palliative care to actually support them through this terrible time. Sometimes I've heard these stories of critically ill children or terminally ill children explaining to their parents and getting their parents to get on board that yes, I know I'm going to die, but I love you, and I just want you to stay here with me, and all this kind of thing. That can be really, sometimes the children can give some wisdom, but it's just they're not ready to hear, except for the child. And then the child says yeah, I'm ready to stop hurting and all that, and that can help. But that doesn't always happen, unfortunately, and so that we want it to be as good as it can be, but losing a child is never a good thing, for sure. So. Okay. I think this is something that y'all can read through, and that this talks about that it's hard to withdraw or withhold treatment with children, because you always have this hope, well, yeah, they're so young, and that maybe this last will work, they need to be strong. And this is really the big thing to remember, and you probably know this. You start when they're the real dying process, actively dying, is the loss of muscle tone and the slowing of the circulation. When you see slowing circulation, what would you see? Cyanosis. Yeah, cyanosis, and maybe mottled looking skin, not real pink, just sort of purplish and pale in the extremities. Changes in respirations, and y'all know what like Cheyne-Stokes and apnea mean? What's apnea? Periods of not breathing. Yeah, and then the Cheyne-Stokes is what? And what'd you say? Well, you can have death rattle too, but rattling while you're breathing. There's lots of secretions and everything, and there are like scopolamine patches, and I think that's in your end of life stuff too, and the anticholinergic kind of things that dry you out. You can put patches on, or there's drops that you can put in their mouth to help with that death rattle. So that's a good point, Jennifer. I'm glad you said that. But Cheyne-Stokes is like periods of apnea, and then they'll stop, and then they'll start again. They sort of start real shallow and real slow, and then they'll build up to some really deep breaths, and they'll kind of and then sigh and quit for a while, and then it'll just sort of build up and die down. And at least that's what I've seen before. And then there's probably different displays of that in different people, but it is like apnea with some changed breathing pattern. And then changes in sensory impairments. But we need to realize that which sense do we need to assume is going to be there until the end? Hearing, yeah. So we want to say things. If we're saying anything in front of, even if they're unconscious or you think they're unconscious and that they are not responding to anything, they still may be able to hear you. They may just not be able to physically move to tell you anything, or to see that they're processing, or so that you can tell that they're processing what you're saying. So anytime you're in a room with a patient, you don't want to be talking about them and saying things that you don't want them to be hearing. You got to leave the room if you need to discuss things that they shouldn't hear, or that you would not want them to hear. Don't assume that they can't hear you just because they're not responsive. And then the nurse tries to do all the holistic kind of comfort kind of things. That's the biggest thing. And the other thing on here is that with feeding tubes, there's not any data to support. It's not evidence-based that you prolong life by giving tube feedings or TPN during end of life. And in fact, well, Hyacinth was going to teach the class about this anyway, but it really makes people worse, doesn't it, Hyacinth? She works with hospice, and it makes some people worse to actually have feedings, because it can cause more breathing problems or aspiration, but a lot of times people don't, or the family members just want to feed. That's always been the nurturing instinct, is to feed. You want to feed, yeah, I want to feed this person. That's a loving kind of thing to do, but that's not necessarily in a dying person. If the patient wants to eat something, then by all means, what do you want? Let them eat whatever they want. And even if there is a risk of aspiration, if you know they're dying and they want something, I mean, you just got to be as careful as you can be. And if something happens, then you gave them what they asked for. But it's not necessarily going to help them to have the tube feedings or the TPN. So anyway, let's see here. Your book didn't talk about that closed awareness and mutual pretense and open awareness either. I didn't remember reading that. Did y'all? But I think it's good to read that at the bottom of the notes page there, because I think most of the time we're doing more full disclosure than ever. But some families, especially culturally, that don't want the patient to know, and that's just the way that they've always lived in their culture, and that's not something that we want to be changing at the last minute either. So. Okay, and then, let's see, and this just gives you more, just examples of all of this, so the modeling and cyanosis and the respiration tube and all that kind of thing. But the death rattle is it's not really a pattern. It's just that they've got a lot of secretions, and that scopolamine and stuff that really can help sometimes, and the morphine too, because it opens up those pulmonary vessels and all, so that can help too. Okay. And then I've got pages 112 to 115 are the interventions and management for the best quality of life at IGGI. I think that's really good. All these charts are so good. And there's another one on page 111 on chart 9-1. So I think I have that written on there. Oh gosh, we've just got so much to do. So but you had to know that from before. That was just a review, so I'm not going to go over that part. Okay. They introduce a single transformed cell just like any cancer does. They can be hormone-dependent, invasive or non-invasive. And there is staging for breast cancer. And in the AD book, they really just keeps referring back to the chapter 24 where it tells you about the TNM scheduling, because it really, as a generalist nurse, you don't need to know everything about the breast cancer staging, which is stage 1, what's stage 2, and all that kind of thing. And so, but they do use the TNM. There's just a lot of categories of it, and it's just difficult to memorize. It's easier to just look at it on a chart if you use it. So they really got so many subcategories. It's hard to memorize the staging. Anyway, in situ cancer, that's something that's been a controversial issue. It's non-invasive as long as it's encapsulated, but it's capable of being invasive. So that's one of those where they're saying it's a cancer, but maybe it's not a cancer. It hasn't invaded yet. Then they're saying now maybe they're not going to call it cancer anymore, but that's still controversial among the experts. So we're going to call it in situ cancer anyway at this point, because it has the capacity of being invasive, but it is encapsulated and it's not invasive yet. So that's where it gets real confusing. So it's really considered like T0 or something like that it's not invasive cancer. So, and then they're trying to decide who should be treated aggressively and how aggressive, and some people just watch and wait, and then some people went out, they don't know about it, so sometimes they just decide, and they get some like hormonal therapy. It's that. Some hormonal therapy or at least definitely the surgical removal, but maybe again watch and wait, and sometimes maybe radiation will be added. Most of the breast cancers are adenocarcinomas, which when you have adeno, that means that it's a glandular sort of thing. And then the most common types, infiltrating ductal carcinoma. And there is lobular carcinoma also. The book talks about the lobular as well, but the infiltrating ductal is the most common that you see. Inflammatory carcinoma of the breast is not that common, but it is. And diagnosis, it's a systemic disease. It just looks like a rash on the breast. It doesn't really look like a usual. But it is a and it starts as a rash and then edema and dimpled skin that looks like an orange peel, and then the Paget's disease is a nipple epithelium kind of cancer. But that's not common at all. But there was a girl from my church that had that, and her mom had breast cancer too. And anyway, it came metastasized through blood or lymphatic system. Just like there's a lot of lymphatics that go through the chest and around the breast. There's the rest and also so there's a lot of lymphatics and the blood is there. The blood is there in these nipples, which is great. And then bone and brain and lung and liver and skin, and especially the lymph nodes. That's going to be the worst thing. Usually the lymph nodes. But you can go to all this. And then there's about too many of them. And on page 1599, this is in the other book. So we have to go all over the place to find all our exemplars on this one. But we're going to use our guide for treatment planning on that page 1599. What in the world is going on here? There's something else in that's distracting. Okay, well, we'll just go on as it's still showing. All right, so we've got non-modifiable and modifiable. Of course, we can't help how old we are unless we want to kill ourselves or something. We can solve that. And then our gender, we can't mess with that, and our genetics, and And if they've got menstrual history, all these kind of things, that's not something that we can do anything about. But we can modify whether we take oral contraceptives and our child. You can't always modify that, because I had my first child at 29, but we started trying when I was 26. So we were just talking about that this morning. That we started like a year after we got married, and then it was 3 years before we had a child. I mean, it just didn't happen for us that quick. So that's not necessarily controllable, but somewhat, I guess. Hormone replacement therapy over 5 years. Not breastfeeding is definitely a choice for some people, but for some people don't have that choice either. I think I told you that my grandmother on my dad's side always blamed herself that her daughter, one of my dad's older sisters, died of leukemia when she was like 32, 33, something like that. And it was, and my my grandmother said that it was because she didn't breastfeed her, that her milk just didn't come in. She had 8 kids and breastfed all of them except for Aunt May. She wasn't able to breastfeed her for very long at all, and she thought that was the problem. And, maybe it had something to do with it. You don't know. But all these kind of things that you can certainly make changes. So the BRCA. Did y'all? I think if y'all will look at that, the stuff that I posted on Smith and Jolene, that's not something I'm going to put on the test board. I think that helps you understand what goes on with the BRCA, because one of them is from Dr. Wiles, and I think he's the medicine doctor, and I think he explained it real well. I think the other article explains it, well also. I mean, it really says the same thing, maybe in a little bit different way, just coming from different points of view, but they're really kind of converged on that this was her choice as far as she definitely had a BRCA issue, because her mom died. She actually got breast cancer at 39 or something like that. Well, no, it was really young, and so she got tested. And not everybody needs to be tested. You need to just see what the history is, because it's not necessarily going to be useful. We can do this manual BRCA test, and we really discourage patients from doing that, because like, what are you going to do with it once you get it if you don't have anybody to counsel you and make recommendations? And you need to do that with a genetic counselor or with a lot of consultation with your doctor before you try that. But the history is the first thing that you want to do about the how many first-degree relatives. The first degree would be a sister or a mom. Parents, I guess if the dad had it, you'd have to kind of call that first degree too. But then there, it has it in English, has some tables and you can tell you what it is. They have a lot of breast cancer navigators nowadays. It's still, we just don't put them in that's been a real, I'm sure, a real help to people that just have no idea what they should do and what decisions to make. And so I think she can help to lead them to the right people to help them make the best decisions. But anyway, it's only about 5% of cases in women over 40. Well, let me say this a different way. In 5% of the cases of breast cancer, women are under 40. But not all of them have BRCA. But it is definitely more aggressive if they have BRCA. 5 to 10% of women with hereditary breast cancer, it's just a very small amount. So it's not like everybody is going to have BRCA. The majority of people are not going to have that hereditary. Even if it's in your family, it doesn't necessarily mean it's not that genetic mutation. You can actually have ovarian cancer or breast cancer, and sometimes even have increased risk for colon cancer. And it can be for men too. Men that have breast cancer are more likely to have come from the BRCA, because they don't have the estrogen to feed it, and so it's more likely a genetic problem in men. And it's mainly in men older than 60. And the diagnosis is delayed though in men, because you're not expecting men to have breast cancer. So maybe a delayed diagnosis. And then they do more advanced stages. Okay, and then
women who begin menstruating before 12 and have menopause after 15 have a slight increased risk, and alcohol consumption can have an effect. And it said in one source an average of 1 drink a day increases your risk by 1.5 times. So that's still, one drink a day. And that doesn't mean saying, okay, I had 1 glass of wine and it was 16 ounces, 16-ounce glass. You can't look at it like that. That's the way some people do. So we have to be careful with that. And look at your cultural awareness box on page 1594. I think we talked about that in some of the statistics about which people are more likely to have it.
I feel like it's good for my.
Usually if it's a cancer, it's not tender, but it can be. I mean, so you can't just say just because it's tender that it isn't cancer. If it's it is a lump. I got a little thing for y'all to. I'll let y'all all feel for the lumps in it on Monday, and y'all do have to start at 8 o'clock on Monday, right? You know that because we're switching off to our deal with our assimilation. So, and it's most often in upper outer quadrant, and that's where the most glandular tissue is. Like I told you, my mom had hers at that inframammary ridge bit right there. So that's hard to feel it. Hers was diagnosed with repeated questionable mammograms. So, and if there's abnormal nipple discharge, that could be that Paget's or maybe not. Maybe it's just traveling. The cells are traveling through some of the ducts. If there's a rash around the nipple or nipple retraction, dimpling in the skin, and changes the nipple position and all those kind of things. It says it's most often found by breast self-exam, and I did get that figure right. But then now some sources are saying that's not really being encouraged as much, that you want to have breast self-awareness, where when you have a shower, look in the mirror and put your hands on your hips and see if there's any kind of dimple or any kind of shape difference, or if you see any kind of rashes or the nipples retracting, or that sort of thing. So being aware of what's normal for your body and then seeing different things. And just realistically speaking, partners can be the ones that find it too. That's a reality that anybody that's been looking, you touch your list, and they find it. And that's certainly to share that information. They may have certain they're seeing a difference in the breast tissue and we'll talk about that with skin checks too. Anyway, we want to do the clinical breast exam at least every 3 years in the 20s and the 30s, and then the early after 40. That article thing that y'all have to read, which is not real fun, but it's a lot of statistics, but that it talks about that U.S. Preventive Services Task Force thing. They're saying to start mammograms at 50 and then do it every 2 years. And you think about Rita saying that she had had mammograms most of her whole life, but she's diagnosed in her 40s, so she was started at 35 and then done every year. And then this gift, and then she died before she was 50. And so you start thinking, okay, what about that task force on missing people? Don't swing them. So the American Cancer Society and the American College of Obstetrics and Gynecology recommends it every year from 40. So anyway, we'll see where that comes out. I think some of that stuff is money saving, and you got to start. We want to save money if it really is not having any benefit. Anyway, even if you're not doing the breast self-exam like every month, like they used to recommend,
you may want to do it sometimes. So if you do see something unusual, and it does have 3 different methods. You got that wedge and the circular and then the vertical strip method, and different physicians will actually do it in different ways too, as long as you cover every video. If you do it the vertical strips, or go in the circular, or do the wedge, sort of like the pie shape sort of thing. Just need to feel all of that, and the professionals are a little bit of that. And with mammography, sometimes you can detect lesions up to 2 years ago. But that's not necessarily what happens to me. I guess it varies this time. I never regularly did so, it was really so anyway, it varies from person to person. Let's see here. You can have a needle biopsy where the fluid or tissue is aspirated from the breast. You can do an excisional biopsy where you actually remove the tumor and then check to see if the margins are clear. If they're not clear, you have to go in and you get more if you're going to just do a lumpectomy. And sometimes they'll do an excisional biopsy and give the woman the choice, of course, of whether they want a lumpectomy or do a mastectomy. And some women are like, just take it off, just take it off. I don't have any worry about losing anything active. And my mom said, well, I have no choice. She didn't have much to start with. She was going to lose, but she got to be there. So, I have a choice, that's what I'll take. And she was diagnosed when I was 35. So it's been 22 years now. So she's doing great. And she's glad she did what she did. So anyway, there are some tests that are listed on pages 1583 and 1584, talking about mammography and ultrasound and MRI. They're mentioned in the breast cancer chapter 2, but you may want to just look over them to get more idea about what that means. And ultrasound is using what? What is it?
And see if it's fluid filled or solid.
It's, what are y'all saying?
See if it's fluid or solid.
If it's fluid filled or if it's solid, and so that's what you want to do with the ultrasound. That's when I saw that Dr. Vasquez that was in that video, because I had just a thickening, but it was just like a scarred gut. Nothing changed, and they said, we've been following you long enough, you're premenopausal. This was cancer. So, but anyway, that's some testing. And they're doing MRI, mainly for people that have genetic mutations or like increased risk. And then Chart 73 woman assessing the breast mass. Like this, talking about the clock face, how you would describe it if you're charting on it, if you are a nurse that's actually doing breast exams on patients, especially an advanced practice nurse. So, gosh, we need to put a break because we're supposed to go 12:30 today, aren't we? Isn't that right? Yeah, it's 12. Huh?
My brain is like,
Oh, I know, I am too, because I'm just like, God. This is awful to have to do it like this. Well, y'all got to do that next year in senior year in that January and stuff. It's like 4 hours and 4 hours and 4 hours in a test. Oh God, I mean, it's tough. So, but anyway, let's do like a 5-minute break and then we'll showing the larger lesion. This one's hard to see on here. It's sort of blurry, but you can see that this is really obvious right there. There's multiple lesions. That looks like that's really close to the nipple. That looks multiple to me too. That one's not as focused. But anyway, that's just what a mammogram picture looks like. So I'm not a radiologist, but okay. Here's a skin dimpling. That's when with that doesn't necessarily mean that, because you can have fat that dimples. That could be fat, but you do need to be. If it's a change, then that's something that you need to be aware of, and that's that breast self-awareness thing. All right, so this is when we get into pharmacologic therapies. But we've already talked about some of these. We talked about tamoxifen, right? And it works by doing what?
Inhibits estrogen.
At the what?
Receptor.
At the receptor site, right, exactly. So, that it's an oral medication. Then we have done that trastuzumab for septic. So, and it's what kind of therapy? Targeted. It's targeted, isn't it? It's actually MAV. Anytime you see MAV at the end, it's monoclonal antibody. It's after one thing. It's after that extra HER2 that's got too many copies of it on the breast cancer cell. So I added this just so that you'll see that Iggy had some of that, and we did talk about neoadjuvant a little bit. That if a tumor is very large before surgery, it's if they take a few doses of chemotherapy, it can shrink the tumor to where it's not going to be quite as extensive a surgery and a lot easier to heal and recover. If you do radiation, that's not, because radiation makes healing more difficult. But with this neoadjuvant, it's really going to be better if the tumor is shrunken, and there'll be less blood loss and all that, hopefully. So y'all have already seen the cyclophosphamide, Cytoxin, right? You learned that for the other cellular units. So this should be familiar to you, and then it breaks the strands, breaks the bonds. And alkylating agents are not in any particular part of the cell cycle. And metabolites work in the synthesis phases of the cell cycle, but they block DNA synthesis. That's like fluorouracil. And then anthracyclines are the red ones that can cause. They're non-specific cell cycle also, but they're alopecia and cardiac effects. There's a maximum amount that you can take to prevent cardiac effects from happening. You can end up having heart failure if you take too much of that. So there's a maximum amount per meter squared, like we do our dosage, and you have to keep adding together to make sure, just like you do with radiation treatment, you have to know how much the patient's had cumulatively over time. And then the taxanes interfere with mitosis. That shows you that you're in that M phase in the cell cycle where the cell division happens, and the taxanes can cause neurotoxicity, the tingling and numbness in the fingers or toes, or just neuropathies and sometimes muscle weakness. And then, and y'all have to really memorize that, but you already know this one and the tamoxifen and that this is just giving you some sort of examples, but this is one that you already know. And I was asking Ms. Hyde, I said, you in your chapters you've got all these, well, even in Kaplan, there's all these drugs, this whole chart of all the different kinds of drugs, and it's like there's no way that a generalist nurse needs to know all of that you really don't, but you do need to kind of have an understanding of some of the prototype drugs. I just want you to realize that you do use combination therapy usually for breast cancer treatment, and the cyclophosphamide actually can be PO in some regimens, but Ms. Hyde was saying they usually, if she said when she's seen a lot, she's just real familiar with the NCLEX stuff because she's been a program director and all this kind of stuff before, and so she says this is the drug that they really kind of would expect you to know, because it's like one of the very first ones. It's the one that came from the nitrogen mustard, that was from the World War I, the chemical warfare kind of thing. And but that's what it derived from the nitrogen mustard and as alkylating agent. So that it was like one of the very first ones that was sort of synthetically made to use for, and they still be used a whole lot in breast cancer. So anyway, and let's see, I think I've got. I wrote down on the notes page about the Femara. That's what Reed took, and I don't know if y'all could even hear all of that. But that one, it prevents conversion of androgens to estrogen in the adrenal gland. And actually, people that are overweight after or obese after menopause can have more of that conversion. Because fat is where it can help
more potential to have that conversion of androgen to estrogen. I don't know the whole mechanism of it, but when you are obese, you are more likely to have more conversion of androgen to estrogen, and then it will feed estrogen-dependent tumors. And so that's what this is blocking, and aromatase inhibitors, that's what it is. Whenever you got ASE at the end, what does that mean? Enzyme, right. So it's an enzyme that helps to convert the androgen. Anyway, in any hormonal treatments, that's something that we need to watch for. So that's something else. I'll let you know. Okay. And then and I had some articles about the chemo brain. Okay. The chemo brain, it does, they recommend like cognitive behavioral therapy and ways to deal with it, but they've just done a lot more research in breast cancer than they have in any other cancer, because it's been like a politically correct thing to do, sort of, and there's so many agencies that raise money for breast cancer research, so probably you can extrapolate it to other cancers, but they just don't have that evidence. For breast cancer, there's lots of evidence that exercise really makes a difference and improves the quality of life and decreases the chance for recurrence and all that sort of thing. And also with the chemo brain thing that women can have it for years. Some people say it gets over with in about 2 years, where there's just some cognitive dysfunction and memory problems and all. But there are some programs that help walk the survivors after they finish their therapy, how they can prioritize, and of course the fatigue and everything you have to prioritize. But with the chemo brain thing, just like organizational skills and things like that can help you. You just feel like you just losing your mind and you can't really keep up with things and all that with the chemo brain. And then one of the articles says you really should call it cancer because it can be from other chemicals that are in the system in terms of cancer, not just the chemo. Anyway, that is something that survivors have to deal with. And there can be stem cell transplants also, but that's people that have high risk for recurrence or already have advanced disease, and that's the only. We'll talk about that in the leukemia unit. But that was one thing that was sort of a standard therapy with people that had aggressive cancers. That you should just that you'd have better results if you had a bone marrow transplant. And this one doctor that was in South Africa was conducting all these studies like institutions in South Africa that was in our country. So everybody was was participating in these research trials, and he was collecting all the data. Well, he was lying about it, and he actually said that it was better than the traditional therapy that they had been doing, and that was not true. And so they all of a sudden stopped it to be a standard therapy. But it is, in real high risk situations, you still may see it, but it's just very rare that you see it anymore because it's really risky. You don't see it. We'll talk about that. Anyway, we do need to know about the surgery. The mastectomy, you can have radical and simple and segmental and modified radical. I'm talking about accidental dissection. Figure 737 on page 1601 gives you a lot of information about the different kinds. They don't even say the radical. But that's what my husband's grandmother had breast cancer when she was in her early 30s after she had all the kids. And I didn't really see her undressed, but just one time I had to watch her. One time she died when she was like 89 years old. But I watched her. They helped her change her shirt or whatever, and she just had a hole, just a furrow. It's just a dug out there. Because it takes everything. It takes the muscle and everything. But she was 89 years old, so it was work. It was good. So that was good in that time. So anyway, you need to know about the post-op teaching and the operative procedures and the post-op care. It's on pages 1601 to 1603. It tells you that the simple is only taking the breaths off. The segmental is a little but it's just you take the lump out and then get the clear margins. When my mom had hers, hers was like they did like a needle biopsy to begin with hers, and then they actually did the excisional biopsy, but didn't have totally clear margins other than the back end, and then they did some rectal dissection all over the earth. In the modified radical, you do the breast tissue, the lymph nodes in the arm, and the chest wall muscles in the top, and then actually lymph node dissection, most of stage 2 mostly. Lesser stage, that's what we did. Now they know we're doing it like 5 out of 6 or something like that. And then the lymphedema can be caused by that, having the lymph nodes taken out. And the sentinel node biopsy is what they're doing a lot. They do that with melanoma some too. They probably do it with some other cancers as well. But they inject dye into the tumor region with the one line and they may have another way to do it. But when they first started doing it, they were lying on their stomach and the table and get the sample of the foot of the radioactive dye. And the first one that shows the dye is the one that comes through the sentinel node. And if they test that one for tumor cells, and if it's the one that the dye feeds into through the lymphatics first from the tumor area, then that's pretty much, if it's positive, then they'll want to do the next one that fills with the dye. But if it's negative, you pretty much feel like if it's gone through that one, if it's always going through that one first through the lymphatics, then the rest of them are not going to. If that one's clear, then the other ones are going to be clear too, because you obviously would expect it to be the one that's closest to the tumor. So that decreases the incidence of what the lymphedema feel like to take all the lymph nodes out and just sample a bunch of them. So anyway, a little